Seems like that was forever ago when that picture was taken, doesn't it?
Yes. I mean, so March 3rd was the big day, and so we're what? 1, 2, 3, almost 4 months since the bill passed.
I know. Seems like another world.
I think since we lived and breathed it so intensely in such like a condensed time period that it does feel like it was maybe years ago.
Right. I know this was like, Ben and I were talking about it. It's been like the last 3 years of our lives. And then COVID happened, right? And then everything just stopped. And it was just grateful every day for the passage. But it was so weird because for 3 years, this was our life. This was everything we were working towards for 3 whole years.
And I talk a lot about that in my part of the presentation. I think people have an idea that legislation basically just happens during a legislative session, but it's the product of a lot of behind the scenes work.
Yes. So, yeah, unfortunately, we can't wave a magic wand.
Well, that would be nice. There'd be a lot of things we could resolve that way.
Oh, I would completely. I'm always jealous when I watch Harry Potter and the Weasley homes got all the cleaning being done automatically. I'm like, please.
Well, good morning, everyone. Thank you so much for joining. I want to go ahead and get started here so that we can be mindful of everybody's time. We have an incredible webinar and presentation ahead of us. We've got some fantastic speakers. So thanks for sharing your morning with us. I want to share some information about Mental Health America of Arizona. Again, my name is Erin. I serve as the Associate Director there. And if you are not familiar with us, I certainly encourage you to come check out our website. We've got some great things going on in the community. Our primary focus is really around promoting the mental health and well-being of all Arizonans through education, advocacy, and the shaping of public policy. So we do that in a variety of a few different ways. And so, our push really is not only ensuring that folks have equal access to mental health care, but that we're really including peer voice, that we're advocating on behalf of families and children and peers, and wanting to engage peers to share their stories, to be involved in legislative advocacy. And so we primarily provide training out in the community. Can't wait until we can be out there again, face to face, seeing all of you, talking with all of you, learning from you. To highlight just a few of our trainings that we offer, one, we have a mental health in the workplace training, which we have partnered with Crisis Response Network to deliver that presentation virtually. So we have had a webinar already that we have facilitated, and so that is recorded and up on our website. But we also provide those workplace trainings unique and independently to your organization, so we can modify them to best meet the needs of your team. So please feel free to reach out to me. You'll have my contact information, and that training primarily focuses on what can both employers and employees do to not only understand or ensure that they understand, what their insurance benefits are, if they're insured through their program or their agency, how to access their EAP programs, but also how to create and support a culture of mental health and wellness and environments where it's okay to show up at work as whole people and know that we bring our experiences with us. The other training that we provide is a legislative advocacy training, and we've been thrilled to partner with Ben and Denise from the GEM Foundation on that training many times, as well as PAFCO. And the focus of that is really for peers and families to help provide support and guidance and a platform for them to kind of practice and prepare and get ready to go out and speak to their state representatives. You know, how can they meet with their legislators and feel confident and prepared to not only share their stories, but really work on promoting self-advocacy and knowing that, you know, peers and families and professionals doing this work in the trenches really should have a voice down at the Capitol. And so that training focuses on really how we can be involved in some of that systems level change. And then similar to the webinar that you're on today, we host community trainings and online webinars, stigma reduction, mental health awareness, things such as that. We also, if you're not familiar, we do have an online mental health free confidential screening tool. So there's actually about 11 screenings that folks can do. If you go online to our website, it'll take you directly to the online screening. And while it's not in a place to go to self-diagnose, as a friend told me sometimes people do on WebMD, but it's really more so about identifying early signs of mental health problems. The hope is that based off recognition of some symptoms, that folks can get early intervention and access to care. And so people can go through, it's a short screening, but based off that information, individuals can, one, determine, you know, regarding what test they took. You know, there's screenings for bipolar disorder, schizophrenia, there's a workplace screening, youth, depression, substance use and abuse. Depending on that screening, they will be provided with sort of a ranking of where they're at based on the symptomology they reported. So are they kind of at stage 1 of mental health problems, or are they identifying at stage 4, where it seems that their experiences are really impacting their everyday, their workplace, their relationships. And so providing some information and education through that screening can help individuals take that, share that information with their doctor, and also help start conversations with friends or families who may be in their support circles. So please feel free to share that tool and resource with your families, your friends, your colleagues, and the individuals that you serve. As you see here, there's a variety of those different tests. And again, it's really a quick and easy way to determine if somebody might need a little additional support. I'm also thrilled to share that we are gearing up for our SEEDS conference. If you have attended the SEEDS conference with us in the past, we've had, you know, SEEDS conference for about the last 37 years or so. And this is our first year where, like many of you, we've had to transition our conference into an online space. So we are hosting it virtually. It's coming up on October 7th. We are thrilled to announce one of our first keynote speakers, Kevin Hines. If you haven't had the opportunity to hear from him, I strongly encourage you to join us. He is a brilliant and beautifully resilient man. He is a suicide attempt survivor. Several years ago, he jumped off the Golden Gate Bridge and lived to tell his story. So please join us. Some of the other topics of focus that we will be discussing is we're having somebody from one of the national partner organizations to speak to mental health in the workplace, and, you know, how we can adjust and recover and continue to be resilient in the work that we do when we're doing it virtually, but also how are we providing services in that sort of online space, you know, telehealth, and what do we do when we go back to work? You know, not everybody is working remotely from their kitchen table. And so we'll have a really fantastic presenter, and he's going to speak to how to kind of get everybody back in gear, and what can you do from a preventative and an intervention response to COVID-19 as you have staff and participants and clients and things like that gathering again. We're also going to have a great presentation from Mesa Police Department and Crisis Response Network to talk about navigating the crisis system and some of the impacts on first responders, but also educating the community about their interaction with first responders and the great work that is being done to ensure, you know, that people who are living with a mental illness or struggling with substance use or abuse are getting the appropriate care that they really need, and that they can get into support services and facilities outside of the criminal justice system. And then finally, you're going to hear from some of our folks who are presenting today, and we're going to be including some legislators to talk about what's happening in the public policy world here in Arizona. We know that things sort of took a hiatus due to COVID-19 down at the Capitol this year. So we're going to bring in some great presenters to talk about sort of what legislative pieces have moved forward, what is the status here in Arizona now that session is over, and what can we expect moving forward in the next year or two, as well as what can we all do to be involved in reaching out to our representatives and being a part of the solution and the change that's happening here in Arizona. Please register. It's open. So share with folks that you work with and anybody you think who might be interested. We do currently have our early bird pricing that is open and available until August 28th. We are offering CEUs. We're still in the process of determining which CEUs we are getting approval for as we further develop the agenda. So please know registration is open. You can visit the website to register, or you can utilize the QR code that we have here. You just hold your camera over it. It'll snap a picture or pull up of the QR code and take you right to the registration page. With all of that being said, I am absolutely thrilled to have so many people here presenting on this call today of, women that I really admire and respect and have had the incredible privilege of learning from and growing with through the process of the passage of Jake's Law, and, as Mental Health America of Arizona, being able to participate on the Arizona Council for Insurance, or the Arizona Coalition for Insurance Parity. We've got a great agenda ahead. So I wanted to go ahead and introduce, first we are going to hear from Denise Denslow. Denise, I'm going to hand it over to you so you can introduce yourself, and then you can merge over to your slides as well.
Okay, sounds good. Hello, everyone. Thank you so much for joining us. And I want to thank Mental Health America, Carly and Bahney, and Terry with the AZ Psych Society for helping us with this and being a part of this. As you know, Jake's Law passed on March 3rd, so we've got a lot to talk about today. I am the executive director for the GEM Foundation. We are an all-volunteer 501c3, and our whole purpose is to end youth suicide. So everything we do is based around that. We do a lot of work with insurance parity, helping people understand their insurance plans, helping people file appeals. We do individual support for the youth, but we also really try to focus on the family. I think a lot of people forget that when a child's in crisis, the family's also in crisis, so we really try to bring in that parental support. And the reason we started the GEM Foundation, January 11th of 2016, we lost our son Jacob to suicide, and he had been denied care by the insurance company on multiple occasions. So we knew that something needed to change. And after we lost our son, we kind of went on this mission to try and make sure that this didn't happen to any other family. So our passion is just to make sure this doesn't happen to any other family, and everything we do is based around ending youth suicide. The age groups that we really focus on is about 12 to 25. That doesn't mean obviously if somebody younger, a little bit older needs help, that we're not going to be there for them, but that's really kind of the age group that we really focus on. So we're here, and as I said, we're an all-volunteer organization. So everything we do is just based around supporting families, providing that individual support, and making sure people can get care. And then obviously, working to reduce the stigma and having those, how do families have those conversations with their kids? Because I think talking about mental health is extremely important. And then Erin, do you want me to go into the presentation, or?
Yes, that would be wonderful. I do want to also share with folks, if you haven't noticed already, we have the fantastic Terry Harnish from the Arizona Psych Society helping us in the Q&A. She's been a pivotal part of this process, along with many community partners that we're a part of the coalition. And so she is going to help on the group chat and manage questions and help provide resources as we go along. So Terry, you're fantastic. Thank you for your help. We appreciate you. Denise, you can go ahead and pull up your presentation and we'll get started.
Okay. Okay, so normally my husband presents with me. Unfortunately, he sends his apologies. He was not able to join us today, but he does say hi and sends his well wishes to everyone. And we're going to do questions towards the end. So just know, I know that some of this can sound a little bit complicated, so we're going to try to break this down in a really easy format. Let me know if you have any questions. We're definitely going to take some time towards the end to answer those questions. So I thought it was important to share our son, Jake. I often talk that it's extremely important to remember that, you know, when we look at stats, there's a family that's affected. There's an individual behind every stat. So I think it's really important for us to remember that for every statistic, there's somebody that's been lost. So this was our son. He was 15. He had just turned 15 a few months before we lost him. He loved hockey, so that's why I put the picture of him playing hockey when he was younger. And I just wanted you to see his face. I thought that was important. Jake just had a way of lighting up a room. He had a really big heart. He had such a compassion for other people. And some would say that he was sensitive. And I remember sometimes, you know, him coming home and talking to me, you know, that, you know, some kids gave him a hard time when he was in elementary school. I know he had really dealt with some bullying in elementary school. He did really well in junior high and high school. He had a lot of friends, but he never really forgot what it was like to be bullied. But he struggled sometimes with his sensitivity. And I remember telling him that his heart was a gift from God and that we need more compassion in this world. And so we need more people to have that empathy and that compassion. And he just had a way of lighting up a room. When he smiled, the whole room lit up. He just had this energy about him. Loved to fly. His dream was to become a pilot in the Air Force. He desperately wanted to serve his country. Loved to eat as well. In fact, the kid even liked Brussels sprouts, even when he was a toddler. I don't know many kids that like Brussels sprouts, but he just loved food, loved to fly. He, like we said, he really had a huge heart. And after he passed, we had so many of his classmates that actually contacted us and said, hey, you know, Jake helped me. You know, if I was being bullied, he stood up for me. If I was alone in a corner, you know, he made sure that I was a part of it, you know. And I remember one of his friends had come on the AFSP walk with us. We did shortly after Jake passed at ASU, the suicide prevention walk. And he had said that he was always alone and they were doing partners in class for a project. And he said he was always alone and never got picked. And Jake was the first kid who went over and said, be a part of our group. So he was just that kid, you know, and he loved hanging out with his friends. He loved posting videos. He had a YouTube channel, loved his dog Loki. Just a really good kid all around. Everybody who met him just adored him. So he really struggled from the time he was about 2 years old. So about 2 years old, I started noticing that something was off. He would get these rages and he would literally like kick a hole in his door. And I remember going to his doctors and saying, you know, hey, something's not right. You know, a 2-year-old doesn't get this freaked out. He doesn't, you know, get this angry. And for a long time, he just, you know, most of his doctors are like, he's fine. He's too young for us to really do anything about. And we were ignored for a good part of his life. When he was 13, it started becoming really bad. And we got, you know, wrong diagnosis after wrong diagnosis. You know, I can't tell you how many times we'd go see a psychiatrist with a recommendation and they would spend 2 minutes with him and diagnose him with a, you know, oppositional defiance disorder or just ADD. And I knew it was more than that. Finally, right before he passed, we got a bipolar diagnosis. And after all the studying and the research, that really seemed to fit best. One thing that I want people to understand is that Jake was far more than his mental illness. And I want everybody to understand that, you know, anybody who has mental illness or struggles with any type of mental health challenge, they're more than that challenge. When he turned 14, he was hospitalized twice for suicidal ideation. The first time was in September of 2015. He was inpatient for 5 days, and then they released him. And then he was hospitalized again in October of 2015. And again, he was kept for only 5 days. The second time, we knew he wasn't ready to be released. I talked with his doctors and said, look, this is the second time he's been admitted in about, 4 to 5 week time span. Obviously there's something more going on. I don't feel comfortable with him coming home. And the doctors agreed. They said, no, we believe he needs longer term care. He should be in a long-term care facility. So the insurance company though said no. And they said it wasn't medically necessary for him to remain inpatient. And we're going to discuss what medical necessity is here in just a moment. But the doctors knew he wasn't ready. We knew he wasn't ready. And the insurance company said, no, he's ready to go home. When we told the insurance company we didn't agree, they said, well, just file an appeal. Well, we're in crisis as much as our son is in crisis. We have no idea what's going on. We get this packet of, 40 pages, 50 pages. It was a huge stack of papers that we got from the insurance company. And, we had no idea what codes to put, what diagnosis to put. We didn't know anything to input on the form. And unfortunately, he had already been released from the hospital. So the hospital was like, well, we can't help you at this point because he's already been released. So we're just in a panic mode trying to figure out how do we keep him inpatient. And less than 3 months later, he was gone. So, I often think back to if Jake had a serious heart condition, and the doctor said he wasn't ready to be home, do you think the insurance company would have said it's no longer medically necessary for him to remain in the hospital? So I want you to really think about that as we go through this presentation. I want you to think about that. If he had a serious heart condition or a serious physical condition and he was in the hospital and a medical doctor told the insurance company he is not ready to go home, do you think he would have been released? So I want to go over some basics of Parity. I know Parity can be, it sounds very confusing, and some parts of the federal law can be confusing when you read them, but it's actually a very, very simple concept. It's basically equality, right? So we want to make sure that the coverage for mental health and substance use disorder are basically equal with physical health. So it should be no more restrictive than coverage for other medical care. So just think equality. So when you think of Parity, I just want you to take that word and say insurance equality and make sure that whatever care you're getting on the behavioral health side is equal to the physical health side. All right, so I want to go over some common terms before we really get into the presentation, because these are terms that you're going to hear throughout this presentation, but even after this presentation, whenever you pull up Parity, you're going to hear these common terms. So I mentioned medical necessity a moment ago, and that's basically coverage for health-related issues. So it basically states that, okay, for example, let's say that you've broken your arm, and the doctors basically state that you need surgery and you need to put pins in your arm. They go back to the insurance company, and the insurance company will say, okay, yes, it's medically necessary for them to have this surgery. So it's basically a decision by your health plan to basically offer treatment, test, or procedure, and they've determined that it's necessary for your health to treat a diagnosed medical problem. So hopefully that makes sense. So basically it's just anytime an insurance company says, yes, it's medically necessary for them to have this procedure in order to treat whatever is ailing the patient at the time. So then you're going to hear the MHPAEA. These are the initials for the Mental Health Parity and Addiction Equity Act, or I'm not sure why that, hold on. We need to get back to, it went forward on me. I'm sorry about that, guys. So the MHPAEA is the Mental Health Parity and Addiction Equity Act, or the federal parity law. So when we refer back to the federal parity law, which we're going to go into detail in a future slide, just know that that's the MHPAEA. Now, quantitative treatment levels, you're going to hear QTLs. These are pretty easy to define. These are basically anything that can be measured financially. So if you have a copay or a coinsurance, an out-of-pocket expense, a deductible, I know many of us have deductibles for our insurance coverage. So when you hear the word quantitative treatment levels, this is anything within your plan that can be measured financially. These are usually insurance companies are pretty even with the quantitative treatment levels, because it's pretty easy to tell if an insurance company is charging a therapist a different copay than a medical doctor. So where we normally find issues with parity, and like I said, we're basically parity just means, equal care, and we're going to get into the federal parity law in here in just a moment. But a lot of times where we see issues with parity is non-quantitative treatment levels, and these are much harder to define. So these are limitations that are not expressed numerically, but they limit the scope of treatment. So I want to go over just some basic examples from you. So medical management standards. This is basically how a health plan determines medical necessity between behavioral health and medical surgical benefits. So how do they determine somebody needs treatment? And then you have the prescription drug formulary plan. So is a prescription drug that's offered at the behavioral health level, is that going to be on a different tier, or is that going to cost more than something that might be used for a physical health condition? These can be a little more difficult to prove. You might need a pharmacologist to kind of determine disparities, but we do see a lot of issues with prescription drug formulary plans with insurance companies. And I want to just do the caveat, not all insurance companies, so I'm just kind of lumping all insurance companies together, but I do want to use a caveat that there are some insurance companies that have been really great with the federal parity law, just not all of them. So, and then provider network admission standards and reimbursement rates. So these are not giving the same rates to mental health providers as you are to family doctors, physical therapists, et cetera. And we often see a huge disparity. Oftentimes throughout the country, a behavioral health provider will only be reimbursed at about 80%, where you'll see specialists that are reimbursed at about 98%. So that's a huge issue. And we often find that a lot of behavioral health providers have stopped taking insurance because, one, it can be very difficult to obtain payment with all the paperwork they have to fill out. But, think about this for a second. If you were doing a job and they came in and said, we're only going to pay you 80% of what you're supposed to be paid, I think I'd be pretty perturbed at that. And we see that, unfortunately, a lot with behavioral health providers. Now, some additional examples, you'll hear step therapy fail first policies. This really, unfortunately, happened with Jake. So when Jake was released from the hospital the first time, he went through an IOP, which is an intensive outpatient program. The intensive outpatient program that he went through did not help him. In fact, we actually found that it made him worse. And it just didn't work for him. So the second time that he was released, they said, we're going to put him back in that IOP. And when I said, look, it's not working for him, we need to find a different therapy, they came back and said, well, he's going to have to fail at this before we're going to put him in something else. And I'm like, okay, but he already failed at this. It didn't work. He's already been through this, after he was released in September. And they said, well, no, he's going to have to fail at this again because he was rehospitalized. So you basically have to fail at something, or you have to go through steps. So you might have to go through less intensive treatments in order to get to where you're supposed to be in the first place. So let's say your doctor wants to prescribe a specific type of therapy for you, right? Oftentimes with physical health conditions, you'll be able to kind of get to that treatment that the doctor wants to provide you. Behavioral health, oftentimes we'll see insurance companies say, no, you're going to have to go through this less intensive. And then once you feel like that, then we'll move you into a different step. And then we're going to move you into a different step. So you're basically having to fail at something or go through step therapy policies. Now, exclusions based on failure to complete a course of treatment. We see this more on the substance use disorder side, oftentimes than we do on the mental health side. But let's say that you're given a course of antibiotics, right? And let's say you have strep throat or some type of respiratory infection, and they provide you with antibiotics. So for whatever reason, let's say you don't finish your antibiotics, and 3 weeks later it comes back. If you go to your doctor and say, look, I'm sorry, I didn't finish the treatment. I know I didn't finish the treatment, but it's coming back. They're going to write you another antibiotic. They're not going to say, no, I'm not going to provide this antibiotic for you. But oftentimes with substance use disorder treatment, it doesn't happen this way. If a client doesn't finish their substance use treatment for whatever reasons, oftentimes insurance plans will tell them that they're no longer eligible for that treatment. So it can be a real issue for those really struggling with substance use disorders. And then standards for access to out-of-network providers. They're supposed to provide a certain amount of providers for, like cardiologists. You have to have so many cardiologists in your network. You have to have so many nephrologists in your network. You have to have so many, endocrinologists in the plan. Well, we're not really seeing that on the behavioral health side. We're not seeing as many providers. And, it's supposed to be the same. So, and we're seeing more and more providers that are actually out of network. And over 40% of Arizonans are actually having to go out of network in order to get behavioral health care. So obviously that's a discrepancy because we're not seeing that many that are having to go out of network for a physical health condition. So you can see how that could be a major issue. So why is there a federal law? Well, historically, insurance coverage for mental health substance use disorder treatment was more restrictive than coverage for other conditions. So there would be, hard limits on outpatient care. So let's say that you only were allowed maybe 10 or 20 visits to a behavioral health provider. And in this case, it's really a mental health provider because really up until the federal Parity law, there really wasn't much for substance use disorder care. You would have higher copays and coinsurance than you would for physical health care. And you might say like, okay, let's say that you need to go inpatient. The insurance company may say we're only going to cover 30 days a year, even though you might need more. They might say we're only going to cover 10 days a year. And obviously we didn't see that same restrictions on physical health coverage. So in 2008, the Mental Health Parity and Addiction Equity Act was enacted. It was a bipartisan law that was sponsored by Patrick Kennedy, and it was signed into law by President George Bush. And it applies to most health plans in America. Now, Medicare is exempt from this. The VA is exempt from this. So just kind of give you, most plans in America have to follow the federal parity law, but there are some exemptions. So what does parity cover? So definitions of mental health conditions and substance use disorder. So what is a mental health or substance use disorder benefit? Remember those quantitative treatment levels we talked about, the copays, coinsurance, deductibles, that all has to be the same. So if you're paying $20 for your family doctor, then you should have a $20 copay for your behavioral health provider. Now, psychiatrists might be a little bit different. Psychiatrists are offered in a specialty tier. So a counselor might be $20. You might have to pay $50 for a psychiatrist. But if that psychiatrist is considered a specialist, then your other specialist should also be at a $50 copay. So, and then strict limits on treatment like inpatient days and outpatient visits. So if you have, a 30-day hospital limit for physical health, then you need to have it for behavioral health. So it has to be equal. And then prior authorization, step therapy, reimbursement rates, and there's many more, but to kind of simplify it, these are all supposed to be equal to what happens under the physical. So their managed care practices are under parity, and that step therapy, like we talked about, those reimbursement rates, those are all supposed to be equal under the federal parity law. And then there's information that insurers must disclose to you upon request, and we'll see that in a future slide. So there's things that you can actually request from your insurance company that they have to provide. So this is our disclosure of information. So let's say that you have been denied. They're saying, hey, it's not medically necessary. Or if you just want to know, hey, what is your medical necessity criteria for behavioral health? Insurers must disclose that. That's part of the federal parity law. Now, under some circumstances, they have to disclose how they design and apply their managed care practices. That can be a little trickier. I would actually recommend that you have a parity expert. If you're getting to that point, obviously you're fighting the insurance company, but their network design plans, in a lot of cases, they have to disclose kind of how those managed care practices are. Right, and then why are we talking about this more than 10 years later? Well, because state and federal investigations are finding that insurers and health plans are not fully compliant with the law. State and federal regulators have been slow to implement the federal parity law. We're seeing some states that have done a decent job at this, where a lot of other states have not. The concept of parity is simple, right? Equality for behavioral health care, it has to be equal with physical health care. Pretty simple, but when you really start breaking down the federal parity law, it's incredibly complicated. I remember the first time I started reading the federal parity law, and there's like math formulas and components, and my husband and I were just like, oh, good Lord. So the federal parity law can be incredibly complicated, and it uses very dense terminology, like unfortunately I know a lot of legislation does. It uses terminology like process strategies, evidentiary standards, other factors that most people are going to look at and go, legalese, right? We don't really understand it. So when we started fighting for this, and I remember, we first started looking, we came across Timothy's Law in New York, that was passed in, I believe, 96. And we didn't even realize there was a federal parity law. I remember we were in a meeting at the Capitol, and Bahney, we started saying what we wanted to do, and Bahney Dedolph turns over and she's like, there's already a federal parity law, right? And we're like, wait, what? And my husband and I pretty much cornered her in the basement at the House of Representatives building and said, okay, tell us about this federal parity law. And then from there, we just, we did everything we could to learn about it. We got involved with the Kennedy Forum, the American Psychiatric Association. Then we started, talking with other people and started building relationships in the Arizona Coalition for Insurance Parity. But as we started really delving in, and started saying, hey, we need equality, we had a lot of people that said, well, there's already a federal parity law, so why would you even need to bring a state law? But again, it goes back to Jake, and I hear from parents all the time, insurance companies are not treating behavioral health equally with physical health. So we knew we had to do something to make sure that they had to follow the federal parity law. So the federal parity law is complicated, like we discussed. States are not enforcing the law, unfortunately. When other states, when they were investigated, the insurance practices have found numerous violations. And if you want to look up WIT versus United Behavioral Health, that's a huge one that came down just over a year ago. And they said, look, they're in egregious violation of the federal parity law. So I encourage you to look up WIT versus United Behavioral Health. It's WIT. That's going to go over some of the violations, and there's others as well, but that's a big one. And then the ACA required that companies provide mental health substance use disorder treatment. But if the ACA is dismantled, some of those protections might go away. So we wanted to make sure that was protected within the Arizona law. And then certain states have enacted parity protections, and we knew that we had to follow. States like Illinois, I believe, were the first to really implement full parity. But we're like, look, no one should go without proper health care because they live in a state that doesn't necessarily enforce the law. So one thing I want you to think about is how parity could have helped Jake. Remember that question at the beginning of the presentation, if Jake had a serious heart condition and was hospitalized twice in a month, would he have been released? And I think that's really easy to answer. He would not have, and I believe that wholeheartedly. If the insurance company was following parity, I do believe that Jake would have still been with us. I think he would have been able to get the care that he needed. They treated mental health differently than they did physical health. And I think we can see that with Jake's case and all the issues that we had just getting him care. They went against the advice of a medical doctor and chose their own medical necessity criteria to release Jake. The doctor was like, no, he's not ready. We said he was not ready, but they said, you know what? We believe it's not medically necessary for him to remain inpatient any longer. And they were requiring us and Jake to jump through more hoops by requiring the fail first policies, make him fail at a treatment before approving another treatment, even though he had already failed at that treatment. And I remember after we lost Jake, my husband was like, well, yeah, he failed, and it was very disheartening because I'm like, I believe had we been able to get him the proper help, Jake would still be with us. And I know I'm not the only parent. I hear this from parent after parent, and there's so many parents that we've now been able to help understand their insurance plans and help them walk through appeals. And thankfully, we've been able to get a lot of children help. But it's just like, guys, just do the right thing, So I wanted to offer, there's some resources that are coming up. We gave our personal testimony. Carly's going to talk a lot about this in the next part of the presentation, but we gave our personal testimony. We actually had to give our personal testimony in front of 4 different committees. This was the first one. So this one was probably the hardest that we had to do. But that's our personal testimony, mine and my husband's at the Senate Health and Human Services Committee. And then at the bill signing, our bill sponsor, Senator Brophy McGee, gave some personal comments, and then we gave comments, as well as Weniger, who was our co-sponsor. And I don't think that video, unfortunately, has Governor Ducey's comments, but it does have everyone else's, and towards the end, you'll see our comments for the bill signing. I didn't want to have to worry about playing those for you today, but I thought if you wanted to go back and hear our personal testimony and see the bill signing, that you could. And then here, and Erin will send this out, so you guys will have these links. We have a whole web page dedicated to how to file an appeal. So there are step-by-step guidelines on how to file an appeal. But if you also want to just pick up the phone and call us or email us, Erin will share our contact information. And we also have a support group. It's Families in This Together. We were meeting once a month, but obviously with COVID, we've had to step that back. And we're now we're a small Facebook group, but we're growing. So if you have a child, and it doesn't matter how old your child is, whether they're younger or older, if you are a parent or a caregiver of a child that struggles with mental illness, we encourage you to join Families in This Together. Everybody that's in this group has a child that's struggling with some type of behavioral health condition. And it's a way for just all of us to come together and support each other. I can't tell you how many times I ended up in my closet crying, just because I didn't know what to do. I didn't know where to turn. So finding that parental support was really important to us and providing that. So I really encourage you to join that group if you have a child that you're caring for that has any type of behavioral health condition. And then we have other resources here as well, the Kennedy Forum, which has been phenomenal in trying to get parity laws passed in every single state. We've got the American Psychiatric Association. They were huge. Tim Clement of the American Psychiatric Association, he's very humble. A lot of times he does not accept praise, but he's been phenomenal with us. And then of course our coalition partners, Mental Health America, the Arizona Council of Human Service Providers, the AZ Psychiatric Society. They have been amazing partners with us. And then you're going to hear from Carly, who did a lot of volunteer lobbying for us. And we joke, I remember we were sitting at the insurance table once and they're like, well, it must be nice to, have a huge organization and be able to, to hire an expensive lobbyist. And we're all laughing because we're such a small organization. And we joke that we paid Carly and Ben and Jerry's ice cream. But you're going to hear from her, and she did a lot of work for us. But now I'll take some questions. I know we went through this a lot. There's a lot of moving pieces. So let me know if you have any questions, and then Erin will share my contact information. So please feel free to reach out afterwards as well. So does anybody have any questions?
Okay, so we'll go ahead. We'll keep an eye on the chat box. So if questions do come in, please feel free to share them. I'm going to go ahead and pull up Carly's presentation. Denise, thank you so much for sharing your heart and your son with us. Hugs to you from across the screen. Hugs to Ben as well. I know that he wasn't able to join us, but he typically does, to stand by and see the incredible journey and all that you have done for families and children and teens in Arizona. It's of course been a collective effort, but the fiery redhead mom just gets things done, and it's just been a real gift and pleasure. So thank you for kind of leading the way on this. Carly, I'm going to go ahead and turn it over to you. I'll pull your information up here, and I'm going to let you go ahead and introduce yourself. Thank you.
Awesome. Thanks, Erin. Denise did a beautiful job laying out the details of the federal parity law and the need for a state law to further enforce the federal law. And so I'm going to get into how a bill becomes a law, how Jake's Law came to be, and to the different provisions of Jake's Law, because the bill was a very large, complex many moving parts and pieces, and it did a lot of things that are not necessarily just parity related. So I will kind of tell you the problem that we tried to solve with each of these provisions and what Jake's Law does, and when that piece will be implemented. But before I do that, if you want to advance the slide, I wanted to introduce myself. My name is Carly. I am a lobbyist with a local public affairs firm called Hamilton Consulting. I have a master's degree in public policy from Arizona State University, and I also have my undergrad degrees from ASU in journalism and political science. This year was my 8th legislative session. My very first session was as an intern, actually, with a different public affairs firm in Phoenix. And I did that, I think, in 2010. And then I went on to get my master's degree and graduated in December of 2012 and started working for the Arizona Department of Administration as their legislative liaison, which is basically just a public sector lobbyist, with a lot of caveats to that. So if you have questions, feel free to email me. And then after about 3 years working for the state, I decided I wanted to see what life was like in the private sector. And I have since then been with Hamilton Consulting. I am a self-proclaimed mental health advocate. And I have recently dealt with postpartum depression, and I'm also a suicide loss survivor myself. I lost my little sister Carlene to suicide 3.5 years ago, and since that have dedicated myself to helping people who want to navigate the legislative process and make change in that way, since that's sort of my area of expertise. And I actually met Ben and Denise through our Survivors of Suicide Loss support group, which is an Impact La Frontera organization. And in our support group, they had mentioned that they wanted to try and pursue some sort of legislation to prohibit what happened to their son from happening to other children and families. And so I told them that I would be happy to help them navigate that process in the best ability that I could. All right, if you want to advance the slide. So I'm going to pull up my own notes here. So now I'm going to get into how a bill becomes a law. And it'll kind of take you back to high school when you learned that process, except that what I really want to illustrate is, a bill the process doesn't just start when there are committee hearings. The process starts way back when. And for Ben and Denise, the process of Jake's Law started probably about 3 years ago. And so first, it's about identifying a problem. And Ben and Denise, Denise told you their story. They believe their son Jake was wrongly denied the appropriate level of care for his condition. And at the time, they didn't know that federal law required mental health conditions to be treated the same as physical health, but what they knew in their heart of hearts was that an insurance company should not be able to deny a child care when one treatment had already failed and his doctors believed he needed further inpatient treatment. So they wanted to tell their story and bring some transparency into the problems that exist in mental health care. So they started meeting with lawmakers to tell their son's story, and they also started getting involved with the mental health community. And in that sort of process, they learned about the federal parity law and what the Kennedy Forum was doing across the country to enforce the federal law at a state level. And this is kind of where I get involved. So I had advised them to start building a coalition, to make connections with like-minded organizations like Mental Health America of Arizona, like the Arizona Psychiatric Society, like the Council, and to seek meeting with the governor's office. I advise them to also engage at the legislature on issues that may be less controversial in order to get a feel for the process and to further build that coalition of grassroots support and to identify sympathetic legislators. And so they started doing this, like 2.5, 3 years ago. And in the process of meeting with lawmakers and telling their son's story, they were guided to a few ideas for legislators who would be an ideal champion for such a complicated issue that would inevitably have major resistance from the insurance industry. So based on some guidance from me, as well as what they heard over and over again from lawmakers at the state legislature and from other advocates in the community, they felt that they should pursue Senator Kate Brophy-McGee. She is the current chair of the Senate Health Committee, and she has had a long history of advocating for both, positive changes on the physical health side and the mental health side. And so after hearing this common refrain from people, they kept trying to get a meeting with her, but the legislative session can be crazy and it's not always an ideal time to have meetings with lawmakers. And so kind of in the midst of all of that, they were able to get a meeting with the governor's office. And that was probably about 1.5 years ago was their first meeting, and it went really, really well. After that, we began to see signals that the governor's office was keenly interested in suicide prevention and making that a priority for the administration. And so probably about this time last year, we had an amazing meeting with the governor's office, and they told us that they wanted this to be one of their major priorities for the 2020 legislative session. And quite frankly, their interest in this bill was a game changer because it backed the insurance industry into a corner. They had to be willing to sit at the table and come to some compromise. I think it would have been possible without the governor's office being a driving force behind it, but it would have been a lot more challenging. And we may not have gotten as much as we did with the final outcome of Jake's Law. So after that meeting, we finally were able to get us a one-on-one with Senator Brophy-McGee, and she listened intently to Jake's story and was just so empathetic and told us that she was just 100% on board, and had actually already wanted to do something in the mental health space during the 2020 legislative session because she wanted to get some additional funding into schools for behavioral health services and thought that this would tie nicely into that effort. All right, so that was a year ago. And the bill passed 4 months ago. So as you can tell, this process has already taken a really long time to come to fruition. Once we had secured our bill sponsor, there was a very lengthy stakeholder process. We had at least 12 meetings to address, both separately and together, the school portion of the bill and the insurance parity portion. During those meetings, other issues came to surface, including issues surrounding hospital discharge, the need to better understand how behavioral health services are provided in a school setting, as well as problems that the DOI, the Department of Insurance, has with addressing consumer issues and problems relating to a lack of consumer education. So all of this ended up getting folded into these two other main pieces of what eventually became Jake's Law. So we were still hosting stakeholder meetings into the legislative session, so like into January of this year. So once we kind of had the outline of what Jake's Law was going to look like, we had to develop legislative strategy. And I think this was more what the governor's office wanted to do, but it was decided to have mirror bills in the House and the Senate. And that basically means that an identical bill is introduced in the Senate and in the House. This is not an uncommon tactic, but it's, it probably happens a few times every legislative session, but it's also not necessarily a slam dunk. But because this was the decision of the governor's office to have mirror bills, a second bill sponsor in the House was identified to help shepherd the bill through the process. And they decided to ask Representative Jeff Winiger to sponsor the House bill. He had been involved in some other suicide prevention related bills that Senator Sean Bowie had sponsored in the couple sessions prior to that. And so they thought that he would be a good champion to get his Republican colleagues on board. So typically, as I mentioned, a bill would go through committee hearings in one chamber, either the Senate or the House, get a whole vote or get a vote by the whole body, and then transfer to the other chamber to go through the exact same process. Having a mirror bill fast tracks a bill through the process because they basically run simultaneously. There was a sense that this session would be abbreviated because there were some contentious political races. It is a presidential election year, and there are just a lot of political dynamics that made us believe that the session would be short. So we wanted to do this more fast track route to get the bill through the process and up to the governor's desk to be signed. Now, I just want to mention that sometimes the mirror bill strategy can backfire because not all lawmakers agree with that approach. They can be a little bit suspicious of the reason for fast tracking something. And it's also kind of exhausting. It is a sprint. As Denise mentioned in her presentation, we had 4 committee hearings within 2 weeks' time. And because committee hearings can oftentimes run long, like you might be spending your entire day down at the legislature for a committee hearing. And so it is an effective strategy if you need to get something up to the governor's office ASAP, but it's also not always the easiest approach to get a bill passed. So that is the legislative strategy. Now we're finally at the legislative process. So bills have to be read 3 times on 3 different days. The first reading, and I think this kind of goes back to like the early days of statehood where you would actually read the entire contents of a bill. In today's day and age, they just read like basically the short title and the bill number. So first reading, they read the short title and then they assign a bill to committees. Our bill was double assigned to health and education in both chambers. Not all bills get double assigned. Sometimes that can signal that there is a political issue with the bill, that they're trying to slow it down, and that's not always the case. I think in our situation, it was probably fair because the bill was so massive and had so many different moving parts. It was clearly related to health and insurance, and it was also clearly related to education. So it wasn't necessarily like a death knell for us, but sometimes on different issues, being double assigned makes you nervous as a lobbyist. So after a bill is assigned, you have your committee hearings. And as I mentioned, we had 4 in 2 weeks' time. After committee hearings, every bill has to go through the Rules Committee, and that's mostly a perfunctory exercise where the committee determines that a bill is constitutional and in proper form. Sometimes it can be used politically to hold up a bill, kind of put it in a drawer so it doesn't go forward, but it's fairly rare for that to be the case. So that's not really a committee hearing that you worry too much about, especially in our case. So after Rules Committee, a bill goes to caucus, and that means that the Republicans meet separately from the Democrats, and the Democrats meet separately from the Republicans, and they can debate the merits of a bill. After caucus, a bill goes to Committee of the Whole, and that's when the entire body comes together on the floor to debate the merits of a piece of legislation. After Committee of the Whole, a bill goes to third read, which is when the bill gets its final vote, if it's been unamended. If it's been amended, then it has to go through a whole final reading process, but that is a story for a different day. So that is the legislative process that Jake's Law went through, and then a bill goes to be signed by the governor. What I will say is that during the legislative session, the governor usually has about 5 days to act on a bill, whether sign, veto, or take no action, which has the effect of going into law anyway. In our case, the governor decided to sign the bill the exact same day that it was passed by the legislature. And that's pretty uncommon. And that was a signal that this was really important to the administration. And so Ben and Denise and all of the advocates were able to come up to have a ceremony commemorating the bill being passed and signed into law. And it was such a beautiful moment. I also want to note that we actually ended up being extremely lucky that the bill passed and was signed when it did, because a week after the bill signing, the legislature imposed social distancing requirements, and then another week later, suspended session due to COVID concerns. So at that time, less than 60 bills had passed the legislature and been sent up to the governor for action. In a typical year when you don't have a global pandemic, there might be 300 to 350 bills that are passed and go up to the governor for action. And so 2 months after all of this transpired, the House and Senate returned, passed another 30 bills for a total of 90, and then they adjourned sine die. So the legislative session ended. So honestly, we were just beyond lucky that this was the way that things transpired. We were lucky to have had near bills because you can't anticipate a global pandemic like that. But I think that Denise and I and Terry feel that our loved ones who died by suicide, that they were looking out for us to get this accomplished, to help other people in the state of Arizona. All right, so that is how a bill becomes a law. The legislature passed the bill and it was signed on March 3rd. The general effective date for Jake's Law, well, general effective date for all bills is August 25th. But in our case, because there are so many moving parts and pieces to it, the provisions are going to be implemented at various times over the next 2.5 years. So now we can get into the major provisions in Jake's Law. And as I mentioned earlier in my presentation, I am going to explain the problem that each of these provisions was trying to solve, and then explain what the bill does to solve that problem, and then I will let you know when it's expected to be implemented. So the first piece is insurance cards. So the problem that we tried to solve with Jake's Law was that consumers often don't know which jurisdiction, whether state or federal, is responsible for enforcement and oversight of their health insurance plan. They don't know who to call or where to call if they want to file a complaint or an appeal. So Jake's Law would require insurance cards issued in Arizona to clearly identify if the plan is regulated by the state and who to contact for questions. And the way that it would do that is that the DOI is, or the DOI is going to be printed on the bottom front side of the insurance card and include a customer service number. So this is going to not only help consumers in Arizona know that their plan is regulated by the state and they can contact the Department of Insurance. It's going to also help the Department of Insurance more quickly and efficiently be able to direct consumers to either state regulators or the federal government if the health plan is governed by the U.S. Department of Labor. So if you have an ERISA plan or another type of plan that's not regulated by the state of Arizona, this designation will not be on your card. You can still call the Department of Insurance, and because that designation is not going to be on your insurance card, they will more easily and quickly be able to point you to the Department of Labor. So this is just a mock-up. I'm not saying this is what your insurance card would look like, but the AZDOI designation will be required to be on the front bottom of the card, include the customer service number. So that's going to start happening for insurance cards that are issued after December 31st of 2021. All right, so the mental health parity reporting piece. Now this is the meat and potatoes of the bill. This is the part that was near and dear to Ben and Denise's heart.
Carly,
yeah.
I'm going to interrupt just a minute, but I'm not seeing the slides moving forward on my screen, and so I'm not sure that everybody else is seeing them.
Yeah, Carly, you're going to have to tell me when you want me to advance the slides. So we're on the major provisions in Jake's Law.
Yeah, so advance past the insurance card piece and then stop at the mental health parity reporting piece.
Oh, okay. Oh, yeah. So moving forward, will you tell me where you're at and where you want me to advance? That would be helpful so folks can all follow along.
Yep.
Thanks.
All right. So the problem that we tried to solve, and Denise did a really fabulous job of explaining the federal law and the need for a state law. But just to reiterate, so although federal law under the Mental Health Parity and Addiction Equity Act requires that insurance companies treat mental health the same as physical health, insured consumers still face barriers to receiving the appropriate mental health and substance use treatment. And many of those barriers arise due to how insurance companies design and apply their managed care practices and their non-quantitative treatment limitations, like prior authorization requirements, medical necessity standards, and requirements for providers to join an insurer's network. All right, you can advance to the next slide. So Jake's Law, in order to enforce that at a state level, will require insurers to file a comparative analysis report with the department every 3 years or whenever there is a major change to the health plan that will demonstrate their compliance with the federal parity law. This might not sound like super impactful, but it reinforces the insurance company's responsibility to comply with the federal law and brings some much needed transparency and accountability, and basically tells the Department of Insurance, yeah, you got to enforce this and you have to pay attention to what's going on. So now regulators are going to have to dig into the issues of mental health parity. And Jake's Law puts an emphasis on how medical necessity criteria is developed and how non-quantitative treatment limitations are applied. So you can advance to the next slide, parity implementation dates. So another piece to the parity provision of Jake's Law is that the Department of Insurance is required to create a web page that has step-by-step guide on how to file an appeal or complaint with the department, and that explains what the federal parity law is and what a consumer's rights are under the federal parity law. And so this web page is supposed to be very user-friendly, use clear language that everybody can understand. And it also will have to help connect consumers that have a plan that's regulated by the federal government to connect them to the United States Department of Labor. And so that is probably the thing that's going to be implemented first. So by January 1st of next year, we should have this parity web page created. The next major deadline is that by April 1st of next year, administrative rules have to be adopted by the department that will more clearly lay out the requirements on the insurance companies. The rules will also establish the types of forms that insurance companies will have to fill out to comply with the reporting requirement, and the criteria that will be used to evaluate their compliance with parity. So this is a point in the process that is open to the public for weighing in. So definitely something to pay attention to. So then the next deadline, sometime during January of, oh, for some reason it looks like you advanced a little bit ahead of me. So by sometime during January, well, sometime during 2022, on a date that's set by the director of the Department of Insurance, insurance companies will have to begin filing these parity compliance reports. And it's just going to take that long for the rules to be put in place and to give the insurance companies time to meet the compliance. So sometime during 2022, the first reports will be filed. However, the department needs time to go through those reports, and so by January 1st of 2023, they will post on that user-friendly web page a summary of the parity compliance in the insurance industry. So based on those reports the insurers have posted. All right, so you can advance the slide again. So then the next major provision is the creation of a mental health advisory committee and Department of Health Services rulemaking. So in our stakeholder process, we found that, you know, a lot of people experience our healthcare system in a way that there is not a uniform approach to helping families when a loved one is in the middle of a mental health crisis. Families feel lost and like they don't have someone who can answer their questions, particularly when it comes to insurance and insurance appeals, transitioning out of the hospital setting and onto the next level of care. Often families feel like they leave inpatient care without clear instructions on keeping their loved ones safe. And frequently, families and their doctors feel that their loved one is just not ready for discharge, but their insurance company deems further inpatient care is not medically indicated. So the way that we're trying to solve that with Jake's Law, if you want to advance to the next slide, is requiring the Department of Health Services to develop protocols for hospitals to follow for patients that are admitted for suicidal ideation or for a suicide attempt, including, you know, contact information for age-appropriate crisis services, information or referrals to the next level of care after discharge, information on the review and appeals process, including referring patients and their families and caregivers to the Department of Insurance website that I mentioned previously, and information on how to challenge an adverse decision by a healthcare insurer. And then the other piece that they'll have to do is to require a suicide assessment before discharge, and then share that information with the patient and the caregiver. And then in order to kind of get to that point, and to help the Department of Insurance on their responsibilities, there is a mental health advisory committee that is established under this law that will help advise the directors of those agencies on information relating to parity, experience relating to parity, hospital case management, hospital discharge planning, and expedited reviews and appeals for cases of suicidal ideation. So if you go to the next slide, I have the committee makeup. So it will include 4 members representing the health insurance industry, 1 licensed behavioral health care provider, 1 member representing a behavioral health advocacy organization, and 3 members who have been affected by suicide or a substance use disorder or a mental health condition. And then 1 member who represents a hospital that provides inpatient behavioral health services. And I think if I'm remembering correctly, it's the latter 2 categories are at least 3 and at least 1, but the first 3 categories are hard caps of 4, 1, and 1. So this advisory committee is going to be established probably pretty soon, sometime after the general effective date. And it sunsets, which means it goes away unless legislative action is taken July 1st of 2028. And rules will probably be implemented about 18 months after the general effective date of this legislation. I do know that the governor's office is already getting recommendations to fill these spots. They're also hiring for a new director for the Department of Insurance, and then that person is going to hire somebody to lead on the mental health parity piece. And at some point, they'll get all of these folks and advocates together to meet the new insurance director.
Carly, I wanted to interject real quick. We have a question here in the chat box from Kara. It says, is the Impact Crisis Network training crisis responders on this info so they can help educate families of their rights when they respond to crisis calls, as well as first responders? Are they receiving training for the same reason?
Oh, I mean, that's a really great question, and maybe something that Denise and I should reach out to Impact on, because I mean, I think that they were tertiarily involved in supporting this effort, so they must be somewhat aware. I just don't know if they're actually, training on this particular topic.
Impact and Crisis Response Network are members of the Arizona Council, and so they have been involved from their involvement with the council. Whether there's been any conversation about specific staff training, I don't believe so, but it's certainly a good idea.
No, let me know, Bahney, if you need any help on that. I'm happy to be involved if that's something that our group of advocates wants to pursue. It's a great idea. Thank you for the question. Was there any other question up to this point?
Nope, you're good. Thanks, Carly.
Thanks, Erin. Sorry, I have my own slides up, so I'm not necessarily seeing the the chat window. All right, so we can advance to the next slide on the suicide mortality review team. So the problem that Jake's Law is trying to solve is that policymakers don't necessarily have enough information to address the suicide epidemic with precision. And so what Jake's Law does is it establishes a suicide mortality review team to help inform future public policy and to address suicide by identifying hotspots, tracking suicide-related deaths, detecting gaps in reporting, and trying to understand the root causes of suicide. The group is going to be comprised of a number of government agencies and 17 other members, including healthcare professionals, medical examiners, county sheriffs, hospital representatives, insurance company representatives, and nonprofits in the mental health and suicide prevention space. So let's see, next slide.
Erin, yeah.
Bahney, did you have a question?
No, I was just going to nudge Erin to advance the slide.
Thank you. So DHS already has taken some steps toward forming this team, and they did that last year, including standardizing death certificate information and developing an online dashboard. And so sometime this month, they were supposed to map suicide and self-harm hotspots and initiate the team. I think because this global pandemic is taking up a lot of bandwidth for DHS. We're probably not totally on track for all of that, but certainly they've already made some really great steps in that regard. So there is something called the Community Profiles Dashboard, if you want to advance a slide, that is meant to allow users, it's an interactive public resource, to allow users to visualize and analyze different health trends. And so they do have suicide as one of those dashboard items. So you can go to that top link to see the dashboard under community profiles. It defaults to cancer, but if you just click the drop-down box under data, and then click mortality, and then click intentional self-harm, then you can get to the part about suicide. But I think this also illustrates how slow reporting is, because the most recent data comes from 2017. So,
Really, there's one question in the chat box regarding the mortality team. Will education be involved in that team?
Erin, hi Erin, I went ahead and addressed that question. I was asking her what specific type of education, because they will be submitting their findings to specific individuals. Obviously, there's privacy issues, so we want to be very aware of that. Amy, I was asking what specific type of education, but they are going to be educating lawmakers on what they find. They are going to be submitting data. They are going to be trying to understand what's happening. That's a huge part of that mortality review team. So are you referring to that type of education, or are you referring to like public education?
No, I'm referring to public education. Will they be represented on the mortality team?
There will be some education, but we have to be very careful as far as like what information is released with that, if that makes sense, just because there's going to be information in there that is not going to be shared with the public, if that makes sense. But everything that is submitted is going to be used to try to understand and implement policies to help basically reduce suicides. Does that make sense?
Yeah, that makes perfect sense. I just know we have to.
I don't believe there's a specific seat on that group for an educator. However, but that is something that we could look at in the future.
Yeah, I mean, I think by and large, we're talking a lot of healthcare professionals, medical examiners, law enforcement. I mean, they're basically going to be investigating suicide deaths, and that might even include interviewing families to just get a better understanding of root causes. So it's a very sensitive subject, and if you read that part of the bill, it is very long because there's so many privacy concerns that had to be taken into account.
Yeah. It's based on the child fatality review teams, which have been going on for 25 years, maybe more than that. And the idea is simply to look at the data and make recommendations about how we can respond better.
So maybe as opposed to a direct educator, somebody more in like a school psychology kind of field would be more appropriate. Is that what you're kind of saying? As opposed to like a teacher being on that, in that kind of position?
Even an administrator, if we're looking at superintendents, because the amount that they're dealing with self-harm and suicide, and the angle that they have, the lens, I should say, that they have to look at the precipitating factors, I think would bring a unique breadth of knowledge to the team. And it should just a curious, like I was curious if we're looking at like K through 12, if we're looking at having some type of a representation, maybe even from the Department of Education, somewhere in that line.
Amy, if you'd like, at the end, we can send you the link to the actual bill. And in the bill, it actually lists out everybody, basically who's going to be involved in the suicide mortality review team. So if you'd want to review it, so that way you have like an understanding of like what healthcare professionals are going to be involved, things like that. So we can send you the link to the legislation if you want, and then we can highlight that part in the bill so you don't have to try to read through all of it. And that way that'll give you an idea of exactly what professionals are going to be involved in that team. Would you like us to do that?
That would be great. Thank you.
Okay, we can definitely do that.
All right, so that sort of concludes the bulk of my presentation, and I think we get to hand it off to Bahney now to go over the school pieces of the legislation, and near the end of her presentation, I'll jump back in with some areas in which you can be engaged.
So we didn't forget schools.
Bahney, before you dive in, just briefly, if we have folks who are joining us who are not familiar with all of the work that you've done for so many years in the field, do you mind taking a moment and just introducing yourself to the team?
Are you calling me old, Erin?
I would never do such a thing, Bahney, but your experience and expertise is incredibly valuable. So I want to make sure folks know all the work that you've done and who you are.
Thank you. I'm Bahney Dedolph. I'm the Deputy Director at the Arizona Council of Human Service Providers. We're a membership-based advocacy organization. We have about 100 members who provide behavioral health and child welfare services all across the state. They employ about 30,000 people and serve almost 1 million clients every year. I'm an old social worker, and so I have done just about every job that social workers can do. And I do like to tell people my first advocacy effort was in middle school, where I decided that we should have a softball diamond at my middle school. And I did a petition. I took the petition to the school board. The school board approved it. And we got the softball diamond. I will tell you, I don't play softball. I never have. It was an equity issue. And I will also tell you that I had some real advantages. My parents were on the school board. It was a very small school district. And I had been raised to believe that you stand up and be heard when you needed to. My grandmothers were suffrage workers. So as we're celebrating the 100th year of women's suffrage, I think we need to remember that and honor them as well as we're talking about doing advocacy work. Is that enough, Erin? Is that good?
That's fantastic. And thank you for sharing that story. That's a really incredible piece about, where your heart first started in this work.
So So mental health parity is very complicated, and getting mental health services to the right people at the right time, whether it's through insurance or at school or whatever, has been unfortunately more complicated than it needs to be. So one of the things that is happening in Arizona is, depending on the school you go to, you have greater or lesser access to behavioral health services in a school setting. You have greater or lesser access to school counselors and social workers. And this access is not always dependent on whether you live in a wealthy school district or not. So the problem that was identified is that while schools are increasingly offering some level of behavioral health services in schools or referring kiddos out to community-based services, it's not happening uniformly across the state. And it absolutely is not meeting the behavioral health needs of all of the students as they And that's, remember, this is an equity issue. So Erin, if you could click for me, please. So what Jake's Law does, and this is like Carly kind of touched on, the complications of making all of the stakeholders in this process happy enough with the bill that they would move forward on it. So, you know, rather than just going in and saying, hey, schools, do this, what it does is it requires access to do a survey of public schools to basically get some information about what they're doing around behavioral health in schools. So, you know, what kinds of staff does the school have? Are they bringing in community providers to provide behavioral health services in schools? Are they just referring out to community providers? Do they have formal or informal arrangements with those community providers? How many kiddos are actually getting services? And really breaking down what's the most common diagnoses of these kids in school. So we've heard anecdotally, you've all have probably heard this, is we're seeing a huge increase in number of kiddos with diagnoses of anxiety or depression, and which, when left untreated, has unfortunate results for those kiddos across their lifespan. So the Access is going to do this study, the schools are going to participate, and we should see the results of that survey the end of 2022. Now that sounds like a really long ways away, but in order to get really good data, sometimes you have to invest some time. And since we don't have any data at all that we're starting out with, I think that this makes sense. Erin, if you could click. So for a number of years now, there has been some money in the state budget that goes to Access to provide behavioral health services in schools. It is for kiddos who are on Access or Kids Care. The problem that we're really looking at is that we really need to do that early identification and intervention, not just because it affects people's entire life trajectory, but also it impacts school success. So kiddos that are struggling with mental health conditions are not going to be able to do well in school. The other part of it is that kids are in school for a real, well, up until COVID, kids are in school for a really long part of their day. And teachers are the ones who are going to be seeing the kinds of behaviors, sometimes disruptive behaviors in classrooms, sometimes internalizing behaviors in classrooms. And so they can help to identify kids that need that early intervention. So currently, as I said, there's been some Access funding to provide these behavioral health services in schools. They were being provided before the funding happened, but again, very piecemeal, very much sometimes school by school, sometimes district by district, the building relationships with community providers. Sometimes, and there's a huge continuum of what those services look like. Some were just like the community provider comes in and provides a service in the school. Some, the school has somebody there 40 hours a week, has their own office. Schools also have the option of hiring their own independently licensed practitioner to come in, and then the school could bill Access to provide those services. What really is at issue here is, how do educators and the behavioral health system work together to support these kiddos? What has been happening, however, is that uninsured children and underinsured children, and this speaks to the parity piece of this, underinsured kiddos are ones who really have crappy health insurance, who have a $10,000 deductible that has to be met before the insurance kicks in and takes over. Kiddos whose insurance is not actually following parity. And also insurance, not all insurance companies would allow what we call place of service code of school. So in order to qualify for reimbursement, it had to be offered in somebody's office, not at school. So all of that is the problem that we were trying to solve around this behavioral health in schools piece. And Erin, if you could click. What Jake's Law does is it appropriates $8 million to specifically to provide behavioral health services to uninsured and underinsured kids. So this, on the uninsured, that's pretty clear. They don't have insurance to begin with. Ideally, what happens is the school and the provider work with the family to get that kid some kind of coverage, whether it's access, kids care, and an Affordable Care Act health plan, or some other kind of insurance. And on the underinsured, it would be able to provide the services until, for instance, that family deductible is met. The schools can provide those services directly, just as they are now, and bill the insurance company, bill access, and then ultimately the insurance company, or partner with community-based behavioral health providers. And this will be implemented as soon as school starts again. So this is kind of the cool part. If you have health insurance, this is a really hard part. And I sat in a meeting with one of the big health insurers and said, hey, I have your insurance. I have no idea how I access behavioral health services through my insurance. And I'm kind of a smart person. I've been doing this for a long time. And they said, well, you call the customer service number on the back of your insurance card. Well, so here's what I'm inviting all of you to do, is to turn over your insurance card and call the customer service number on the back of your insurance card and say, how do I get behavioral health services through my insurance? And then if you are actually seeking behavioral health services, I want you to stay on the phone with that customer service person until they find you an in-network behavioral health provider who has openings and can see you in less than 6 weeks, ideally. And if they can't do that, then they don't have an adequate network. And then you have a parity violation. So this is not a simple answer. It may mean sitting on the phone with somebody for an hour or two until they find an in-network behavioral health provider for you. Do not let them say, well, they're all posted on our website, because that's just the burden shouldn't be on you. The burden should be on the insurer to connect you with an in-network provider. Because they told us they have adequate networks. So let's make them demonstrate that. And Erin, I think we can click. If you don't have insurance, or someone you know doesn't have insurance, the first step is to apply for access or kids care if there's any possibility of eligibility for those things. Especially in these times of high unemployment, I think there are probably many people out there who would now qualify for access or kids care that did not qualify before. You apply for an ACA marketplace plan and get a subsidy. Now, here's the deal, and I said earlier in the chat, if you have less than optimal insurance on the physical health side, you are going to have less than optimal insurance on the behavioral health side. So be very thoughtful when you're looking at those bronze and silver and gold and platinum plans, because if you choose the bronze plan, you may have less than optimal insurance. And even though you're paying for that insurance, it may simply not have very good benefits for you. On the ACA plans, that, as was mentioned earlier, mental health and substance use disorder treatment are one of the 10 essential health benefits that they have to cover for you. And so, Erin, if you could click back one slide, please. So they do have to cover it. They don't have to cover it well, just like they don't have to cover physical health well. And then if neither of those things work, talk with the school counselor, social worker, or teachers about resources that are available through your child's school. There are some resources that are available if your kiddo has an IEP, for instance. And ideally, we will have school districts working to make sure they either have staff on hand or they've partnered with a community provider to provide behavioral health services in schools. Now we can click, Erin. I want to talk a little bit about how you access some resources in the community. The 211 Community Information and Referral number is, again, live, as is their website. And there's a boatload of resources that are available through 211 for people, both related to COVID and also just related to community resources in general. And Erin, we can click. And then the Crisis Response Network crisis line here in Central Arizona. There are crisis services throughout the state. So if you are coming in from someplace that's not Maricopa County, there are crisis services available to you as well. This is both a phone line, and they can send out crisis mobile teams to help anybody experiencing a mental health crisis. And then, Hartley, is this you?
Yeah.
Okay, I'm done.
Before you hand it over, Bonnie, we have a question from Pat. For behavioral health in schools, can the funds be used for preschoolers?
I believe the language is under a certain age. The question becomes, does the preschool have either those staff on hand or have relationships with community providers? So I think it is possible. I don't know how probable it would be.
Because if they're not providing the services directly, then they would have to make a referral, right, Bahney?
They could make, I mean, anybody can make a referral at any time to a community provider. Parent can.
But to trigger that funding.
Yeah, to trigger the funding, I guess if a preschool had a psychologist or a independently licensed social worker or counselor on staff and wanted to bill for it, they could do it. Oh, you're thinking about the preschools that the schools offer, then definitely, yeah. Yeah, if the school is providing the services or has partnered with a community-based organization, I think that would be very possible.
And how do you guys see some of those partnerships going? That's kind of where I'm interested. I know as a behavioral health case manager for foster youth, it was very difficult to get them the services they needed when the providers were available. If it meant they had to miss 3 hours of school to get 1 hour of therapy, it was kind of a difficult balance. And so are you considering are we thinking about partnerships as far as, some of those Teros organizations or JFCS and things like that actually maybe having an office on schools, on school campuses, and looking at partnerships that way, or more through the referral process and whatnots. Because I know with CFTs and whatnot, I was always trying to get information from the schools and get schools in on the CFTs as much as possible. And it was always a very difficult process.
So there's a lot of effort that's been going on over a number of years to address the issue of meeting kids, essentially meeting kids where they are, which is school for many of them. So a number of our members have existing relationships or are building relationships either with school districts or with individual schools. Because we have local control of schools, that can't be something that happens statewide. So it's really up to the school to allow that service to be provided in the school. And some schools actually have an office for the community provider in their school, and that they see the kiddos and they work with teachers to provide the services at school. They work with teachers on classroom management issues. We also, the council's been working for 3.5 years with Dr. Bruce Perry on the neurosequential model and caregiving program for foster kinship and adoptive families. And about 80 schools were trained in Dr. Perry's neurosequential model in education. And so there is kind of a growing number of schools and school districts that are kind of jumping on board, both in educating and their teachers and staff about the impact of trauma on kiddos, but also in making sure that kids get those early intervention services when they can. That does not mean the system is seamless and it's working marvelously.
Yeah, but they should be able to start having those providers on their campuses be billing out so that they're not totally reliant on the school's budget to fund them, right? That's where
this would be, this $8 million would not be coming out of the school budget. They could bill for that. Now, you have to get that independently licensed person who has an access ID and bill access to be able to do that. There are some schools that's the way that they're doing it. Other schools, I represent community providers, so I think it's a good idea for them to partner with community providers.
Yeah, administrators and whatnot that I talk to that don't know about this, that's kind of where I'm.
Yeah.
I mean, as far as my recommendation means to them, but that's kind of where when I bring it up to them, I talk about, well, look at some partnerships, look at what you can do to get it out of your budget and into the insurance provider's budget.
Yeah. It's interesting because I've spoken to school administrators who are like, yeah, we really want to get behavioral health services in our schools. And I talk to my providers and they say, we're already there.
Yeah. I know. But it's still, right? The seamless part of it is hard.
Just in the interest of time, I want to quickly go through my last couple of slides. So if you want to be engaged, first learn your rights relating to Parity. The GEM Foundation is a great resource, and they provided in their slides a lot of really amazing resources. So I would direct you back to that. And they mentioned the Kennedy Forum. They were instrumental in helping to educate both me and Denise, as well as the American Psychiatric Association. Our model legislation came from them. And then the Arizona Department of Insurance, once their webpage is live, it will hopefully help people better understand Parity and what what their rights are. The other way that you can be engaged is to file complaints and appeals. So investigations often stem from the trends that the Department of Insurance sees in their complaints and appeals. What we heard in our stakeholder process from the department is that they don't really investigate things until they see like a red flag. And so, obviously go through the proper channel with your insurance company, but if you believe that you're not getting anywhere and you have a legitimate parity violation, then file the dang complaint. Because we need the regulators to see that these problems exist. We need them to pay attention. We need them to continue to make this a priority. And so the only way that they're going to see that a fire is burning is if we do our part to show them where the fire is burning. And then participate. Pay attention to the rulemaking process. That is a public process. That way that we can keep a pulse on how this law is being implemented. But also call and meet with your lawmakers. The regulators and your lawmakers, they don't know what they don't know. And I have to say that personal stories and testimony are so powerful because they bring to life these otherwise really dry issues that are hard to understand. So I would just encourage you to, be the change in that way, to participate by meeting your lawmakers and file complaints and appeals when there's a legitimate parity violation. So if you want to go ahead and next slide. So if you want to file a complaint, contact the Department of Insurance and Financial Institutions. That is the phone number, their email address, and then the precise web address for filing a complaint. Next slide. I just wanted to give a shout out to everyone who was part of our insurance parity coalition that helped make Jake's Law a reality. The Arizona Psychiatric Society, Mental Health America of Arizona, the Council, My Kid, the Arizona chapter of the American Foundation for Suicide Prevention, and all of the individuals, including those who are on the call today, who are part of those organizations, and the individual advocates and suicide loss survivors, because honestly, this would never have been possible without the grassroots support of everybody who was involved. Your personal experience and testimony is so powerful. And I think that Denise had some comments that she wanted to make too, about that kind of in particular. But, this was a really major labor of love, and I am so proud to have been part of this group and with all of these amazing, amazing people. I think that this is going to make a difference in Arizona, and I hope that, in laying out what this law does, that you see the impact that it's going to have in the future.
Wonderful. So I know that there are a few questions here. I think, Terry, we're going to have you chime in with those. Before we do that, I want to definitely make sure that we give Denise an opportunity to say any kind of closing comments or thoughts. As also mentioned, we can follow up directly and independently with some of the questions. You all have had great input and feedback and questions. So Denise, you still there?
Yes. So I wanted to say thank you. Thank you again, Erin. Thank you to everyone who joined. When we started the GEM Foundation, and really started putting the Arizona Coalition for Insurance Parity together, it's been such an amazing team effort, and like Carly said, this would not have been possible without our coalition members. So we just really appreciative for that. It really is a grassroots effort. And, we know the bill doesn't solve every problem, right? We know that there are still a lot of behavioral health issues that we have to solve, but the bill's 15 pages long. Like, it does a lot. And I am enormously proud of the bill and the work that we accomplished. You know, we started the GEM Foundation. Our main goal was to get this parity legislation passed, and we were able to do so much more than I think any of us originally thought we were going to be able to get done. And I remember when we started this, you know, because we really started emailing legislators about 3 to 4 months after we lost Jake. And when I started really understanding, you know, what parity was and what we were trying to accomplish, we had so many people tell us this will never happen in Arizona. Forget it. You're crazy. You're wasting your time. Like, we heard this from so many people and a lot of organizations. And I think this just really goes to show what we can accomplish when we come together, you know, and I really believe that together we can move mountains. You know, and that's what grassroots efforts does. I mean, Ben and I aren't special. You know, we're two parents that just didn't want this to happen to anybody else. We didn't know anybody. You know, when we first started this, we didn't even know how, you know, really, I mean, outside of, you know, our civics class, we didn't even really understand fully how a bill became a law. You know, we didn't have any special, you know, I guess I'm trying to say we just didn't have any special knowledge. We just built the relationships and really started meeting with people and really started talking with people. And I just want you to know that, you know, if you are sitting there going, you know, I don't know how I can make a difference. I don't know how I can do this. I'm telling you, one voice makes a difference. And when one voice becomes 2 voices, becomes 3 voices, becomes 10 voices, becomes 100 voices, etc., I do honestly believe we can move mountains. So thank you all so much. And this was a team effort. And I every day I say a prayer of thanks for Jake's Law and what all of us were able to accomplish, because this was absolutely a team effort and we were absolutely blessed by everyone that fought with us. So thank you.
Wonderful. Thank you so much, Denise. And a special thanks from Mental Health America of Arizona for the opportunity to host this webinar today, and for all of you bringing your expertise and your experience and your passion to this virtual space. Please take a moment to follow up with us. You'll be receiving an email from me with the evaluation. You also have the link to that in the chat box. I've also shared all of our contact information in the chat box, which will be in the webinar or in the email as well. And then you will receive a copy of today's PowerPoints. A special thank you to Terry from behind the scenes for providing all of the incredible links and resources for us to use moving forward. I'll be sure to include that as well. Please reach out if you have additional questions, and we will get our team together to make sure that we respond to those. Thank you, everyone. Please stay safe, and we'll see you next time.
I think just one question, Erin. Will the recording be made available?
Yes, the recording will be sent out as well. Thank you, Terry. All right, everyone, have a good day. Thanks for joining us.
Thank you all so much.